If people in their communities are not aware that this disease is taking so many lives, nothing can be done.
There's an astonishing level of ignorance about the sheer scale of this crisis. 800,000 children, one death every 40 seconds. The world needs to know what is happening.
I have the pleasure and the honor to present that strategy to this audience.
In order to address pneumonia, I am proposing to do a solid advocacy with the state governments that this is a disease, which can be eliminated, which can be we can end that pneumonia.
Le sprint va permettre au Sénégal, dès la première phase pilote qui durera 1 an, la prise en charge de 300 000 enfants. À la suite de cette phase, il y aura une mise à l'échelle au niveau national.
Et ce que nous sommes en train de faire, c'est qu'en profitant en fait de la réforme pour la couverture sanitaire universelle, nous allons adresser un plan qui va nous permettre de prioriser toutes les interventions liées à l'enfant et la mère et ainsi apporter des ressources pour financer les interventions directement liées pour réduire la mortalité infantile, entre autres en lien avec la pneumonie.
Also, we are going to establish the bubble CPAP and also the oxygen in every facilities and pulse oximeter. We are now going to start this type of facilities in the sub-district.
Well, first of all, we have to ensure that we have the budget in place, adequate amount of money for commodities, for vaccines. We are also going to introduce what we call community health extension workers that will be integrated into the system and paid a remuneration so that they are motivated to do their work.
Qu'est-ce qu'on a fait? La Côte d'Ivoire a mis en place 2 grandes politiques. La première, c'était la gratuité des soins pour les enfants, incluant les médicaments. Et la seconde, c'était la politique de santé communautaire qui avait pour objet de rapprocher les populations des centres de santé.
Pneumonia, it is not just for the health cluster responsibility, but it must be a multi-sector. So all the elements of the government, from the village until the central government, and also into the regional area is also involved. So we have to fight it together.
So after this meeting, we in collaboration with the partners which are working in South Sudan, like Save the Children, we hope to be able to have a mechanism to access vaccine against pneumonia.
Each child will have access to screening, to testing, and vaccine. And with UNICEF and other partners, we want really to make sure that this fighting for breath will become a reality.
It is very clear in my mind that the most important commitment is for governments to recommit to invest in primary healthcare and integrated primary healthcare in reality and deed.
Agencies like UNICEF are standing behind you and are ready to support you to build and deliver community-based, accountable primary healthcare services in all contexts, humanitarian and development alike, in which children and family can get all the services that they need in one place.
So it's very important to get to each and every society, whether they are rich, whether they are poor, because every single life is very important.
Good morning, everybody, and welcome. My name is Kevin Watkins. I'm the CEO of Save the Children in the UK. And I want to welcome all of you to this really important anniversary event. It's now 1 year since we convened the World Forum, and it has been a year, I think, that none of us could have imagined. The desperate suffering caused in so many countries because of the pandemic, the stress placed on health systems across the world, the personal stress, the financial stress. And here we are 1 year on, and I think we have an opportunity both to celebrate the extraordinary progress that so many countries have achieved despite the pressures that have come with the pandemic. But it's also an opportunity for us to reflect on the challenges ahead and to identify ways in which, working together, we can take the struggle against childhood pneumonia to its next level. I think the speakers in our first session are going to set out some of the stepping stones towards the future that we all want to see. This is a group of countries that have registered extraordinary progress, whether it's through the introduction of PCV into their general immunization programs, as in countries like Indonesia and China, whether it's in support for the development of pulse oximetry and oxygen. All of the countries on the panel this morning have an important story to tell, a story that all of us will have an opportunity to learn from. But I think the great challenge that was there a year ago is still there with us today. Childhood pneumonia remains today what it was a year ago, which is the biggest single infectious killer of children. We know that countless lives are being lost for want of very basic interventions, whether it's the PCV vaccination, antibiotics, or access to medical oxygen. Ensuring that these vital inputs are available to everyone, regardless of their wealth, of where they live, is, I think, a measure of equity in health systems. And we build equity in health systems not just by pronouncing the virtues of reducing inequality and fairness, but by putting the investments in place. Investments where they are most desperately needed, which is among the poorest communities living in rural areas and in slums and villages across the world. We have an opportunity in this session to hear about some of the practical measures that we can take. I want to, before I hand over to the moderator, I want to encourage all of you to take a quick look at the logistics slide. There's an opportunity for all of you who are not speaking to contribute in the chat, but please do take a look at the logistics slide, which will give you a bit of background. Just to remind everybody that this meeting is being recorded. Now, I want to pass over to our moderator for this session, Ji Soon Song, who is a principal advisor in the social sector for the Asian Development Bank. Ji Soon, it's with great pleasure I pass over to you to get our proceedings underway. Thank you.
Thank you very much, Kevin, for kind introduction, and good morning, good afternoon. Welcome all to the Roundtable on Financing and Innovation. I am privileged to moderate the session with distinguished speakers on the two critical aspects of the Global Forum Declaration. Pneumonia is one of the leading killers of children under 5. It is certainly preventable and treatable, but well-known causes such as malnutrition, air pollution, slow adoption of vaccine, lack of quality services and access, preterm birth, etc., still remain as challenges. My role at Asian Development Bank is to help the developing member countries in Asia and the Pacific strengthen their health systems and to achieve universal health coverage as a way to address the multifaceted poverty and inequality. From my experience, financing and innovation are two sides of one coin called prioritization. We all witnessed how countries around the world mobilized and applied unprecedented amounts of resources, both financial and intellectual, to address COVID-19, which comes on top of the list. COVID stopped many things. However, not all is lost. As Kevin mentioned, it rebuilt the weaknesses in every system, even in the developed world, and then pushed us to find solutions. We will hear examples of governments and dedicated professionals increasing domestic financing to improve the child health services and leveraging international assistance for COVID in the ways that will actually benefit children, including children with pneumonia. You will hear about how new investments are made for vaccines, innovative diagnostics and treatments, and integrated service delivery models, which have a potential to transform not just pneumonia care, but the care for sick children more broadly. Measures taken and systems developed for COVID-19 will help us address other infectious diseases effectively. We have to. This session will consist 2 parts, one on financing and the other on innovation. Each part will be followed by discussions among the speakers and the country delegates. We encourage wider audience to use the chat function to share views. It is my pleasure to introduce our first 4 speakers on financing issues. In the order of their flash talk slides, today we have Dr. Dan Wu from National Immunization Program of CDC China. Dr. Siti Nadia Tarmizi is the Director of Communicable Disease Control and Prevention, Ministry of Health, Indonesia. Dr. Jessica Nusungwa Sibiti is Reproductive and Child Health Commissioner, Ministry of Health, Uganda. And our last speaker for the financing will be Dr. Humphrey Nusona, Manager for Integrated Management Childhood Illness Unit, Ministry of Health, Malawi. Speakers will have 7 minutes each. With this, I will invite Dr. Dan Wu. Please kindly proceed. Thank you.
Thank you, Song, for your kind introduction. And good morning and good afternoon, everyone. It is my pleasure to be here and share the topic, Introduction of the Pneumococcal Conjugate Vaccine in China. So for vaccines inclusion into expanded program on immunization is very complex, based on science and also practice. At present, there are a total 14 vaccines are in China's EPI program, and 11 of them are routinely used in children, and at least 14 doses have been administered under 1 year old. Therefore, new vaccines inclusion will consider combination with the present ones, and there are several vaccines are not included in China, such as HIP, varicella, rota, and also pneumococcal vaccine. So pneumococcal vaccine conjugate vaccine is recommended as non-EPI. Previously, we called it Category 2 vaccine in China, which means the vaccine should be paid by individuals instead of a government. Now, two manufacturers are providing PCV13 here. One is domestic and the other is international. The table below shows the manufacturers' intended use, schedule, and price per dose of the products. The mechanism for vaccine inclusion into EPI needs to be improved, not only based on the outbreak's control or experience. Therefore, the National Immunization Advisory Committee, we call NIC, was founded in 2017. Its function is similar as ACIP in US or GCVI in UK. And together with the financial department of the State Council, established a dynamic adjustment mechanism for the types of vaccines in EPI. So vaccine technical working groups, including Pneumococcal Vaccine Working Group, were established to provide evidence for decision-making reviewed by the members of NIC. So next slide, please. There are several challenges or insufficient evidence for inclusion of PCV into EPI. First, the disease burden in China is unclear. Pneumonia is not one of the notifiable diseases in China, indicates no systematic or continuous surveillance giving the data showing incidence or trend of this disease, impeding the decision-making. And clinical features of pneumonia in children may lead to awareness. So pneumonia can cause by many antigens, and bacterial pneumonia have effective treatment, since it is not like varicella, can cause outbreak and get more attention from the government. Second, the high price of PCV vaccine in China compared with the EPI vaccines is a brake on the vaccination willingness and inclusion into EPI. So limited financial resources make the choices more difficult when prioritizing public health interventions. Third is about the limited capacity for PCV's immunization. There are only 2 manufacturers providing vaccines. The birth cohort in China is approximately 15 million per year. So the insufficient supply of PCVs lowers willingness of POV physicians to recommend PCVs. Besides, the complex, strict immunization schedule and also have to combine with other vaccines lowers compliance and completeness. Therefore, there's some works needed to be done to move forward. The most important thing is strengthening the epidemiological surveillance and monitoring through the pilot or sentinel surveillance to obtain epidemiological characteristics of pneumonia in children and make cost-benefit analysis of PCVs. Secondly, is exploring financial mechanism of PCVs, either partially subsidized by government or through the commercial insurance. And as far, these have been done and explored by some academic institutions in China. Third is encouraging the vaccine manufacturers to increase PCV productions to ensure the capacity, guaranteeing the sufficient supply or the supply ability. So thank you for your attention. That's all my presentation. And also thank you, Huang Xiaona and the colleagues of this meeting's help.
Thank you very much, Dr. Dan Wu. The next speaker is Dr. Tamiji. Seems like she's not yet here. So I would like to invite Dr. Saviti, Dr. Jessica Nosungwa Samiti, to proceed, please? Dr. Jessica?
Hello, good afternoon from Uganda.
Yes, ma'am,
Hello.
please.
Okay, good afternoon from Uganda, and I bring greetings from the Minister of Health, who was not able to join us because we've just launched the COVID vaccine, and she's steering a big meeting this morning of high-profile people. So my presentation today, I'm going to share with you our journey, our experience so far, focusing mostly on the financing aspect of the control of childhood pneumonia in Uganda. As a summary, I want to say that since the last meeting in Barcelona and the other meetings, previous meeting, the main focus has been on the continued advocacy and the big push to break the vicious cycle of insufficient funding for pneumonia, limited evidence base for advocacy, for increasing funding, especially in a holistic manner, looking at both public and private sector, but also the need to emphasize the reach to the community level. And lastly, the lack of a clear transition plan, especially for donor-funded interventions or aspects in the effort to control and prevent pneumonia in the country. So as a first main activity or aspect of focus we've been focusing on, we have been focusing on scaling our financing. And one of the areas we went on right on was to attract new external support. We were able to mobilize $4.8 million for commodities from the Global Financing Facility. We got an allocation by government from the Global Financing Facility. You're all aware that the Global Financing Facility is matched with a government loan. So we were able to prioritize amoxicillin as a commodity for pneumonia treatment. Additionally, the GFF financing and the World Bank project, which is supporting maternal newborn health, also is extending resources to health facilities for performance-based financing. And these resources are used by the health facilities to fill gaps across their range of needs, including product procurement. And through this process, we've been able to mobilize an extra 1.6 million US dollar procurement, funding for procurement for medication for pneumonia. So in total, we've been able to mobilize a cumulative total of about 6.35 million US dollars for amoxicillin, dispersible amoxicillin between end of 2019 and 2020. This has seen us increase volumes of amoxicillin procured gradually over the last 3 years, with figures ranging from 6.5 million doses to 17.6, and last year 37 million doses, which we think is a great improvement from the previous years. So that was the first main area we tackled. The second area has been a big focus on trying to crowd out domestic resources. We've been emphasizing the need to transition and have more domestic resources. And in September 2020 last year, we went into a collaboration with the Research for Development organization, which is funded by the Bill and Melinda Gates. And we did a deep dive analysis on the maternal newborn child health products or commodities in the country. And specifically, we analyzed the budget. We wanted to eliminate the budget allocation. We wanted to see the procurement process and actually track the commodity, how this money reaches the grassroots. And this exercise took about 3 months. And the recommendations from that exercise were very instrumental in what we have done so far. So what did we do? One of the things we realized from this deep dive analysis was that
we needed to have greater coordination to guide the estimates of medicine needs for pneumonia, which are currently quantified under 3 separate mechanisms. We have an essential medicine health supplies team, which does quantification in government. We have a pharmacy division, which is doing quantification and also guides procurement by donors. And then we have the national medical or central medical stores, which also quantifies medicines using credit lines for allocating medicines to districts. We also found a disconnect between the quantification and the volumes actually procured by the national medical stores and donors. And what did we find? We found actually that only 15% of the procured volumes were similar to the quantified volumes. And this we did not know. We only knew the amount we were allocating, but we had not tried to match it with the actual procurement. The other third finding we found from this analysis was that despite these 2 challenges, that specific medicine availability at our public health facilities was actually not directly tied to the medications which were procured at the volume which had been quantified. So we actually found, for example, that amoxicillin 250 milligram DT, we were procuring twice as much as the quantities which we had planned for. But only 19% of the facilities during that rapid assessment had actually adequate stocks for the next 3 months. So there was a lot of discrepancy. So this exercise we did with the in-house exercise we did with these partners have helped us to crowd out other resources, domestic resources, for being able to procure more commodities, but also support the service delivery, including capacity building for pneumonia. So the third item, things which we have done after that deep dive exercise, is that we've been able to promote and push for the government to institutionalize paying allowances or wages for our community health workers, especially those who are working on the Community Case Management Program, or ICCM. You're all aware that the ICCM program supports lay workers to treat under 5s with pneumonia, malaria, and diarrhea. And this has been a flagship program for the country. So by paying these volunteers, we are hoping that we will be able to not only improve their participation, but also reduce the dropout, but hopefully we'll be able now to regulate them and manage them better so that we are able to increase access at that level at the community. Fourthly, while the donor support for these medication or commodities has increased in the last 4 years, as I've reflected, compared to the previous 5 years, we have been working very hard also and negotiating to secure more funding beyond the financial year 2021. We seem to have better security for the commodities, but the funding beyond 2021 was a bit hazy. So we've been negotiating, and we're in advanced stages to negotiate with the Global Fund to sustain some of the ICCM funders or donors. We have DFID, which has been funding and is coming to an end this year, 2021. And we are now negotiating with the Global Fund to be able to take over these 61 districts to be able to cover the gap. And these discussions are in advanced stages. We are also working on developing an ICCM specific investment case to support mobilization of resources. And we're working with USAID, Save the Children Fund, Uganda International, and UNICEF to be able to put this investment case across. We're going to use this investment case. It's informed by the costs we are anticipating. It's informed by the available resources. It's also informed by the forecasts resources we expect. Therefore, we'll be able to have a tool which we'll be able to use for mobilizing resources, but also for dialogue at the policy level. And the sixth step we have done is to develop, we've developed a costed national scale-up plan for medical oxygen implementation. We developed this plan before COVID in 2018, and this plan runs up to 2022. It has been costed, and we have been using it to advocate for oxygen delivery, including especially pediatric cases. Until recently, when COVID came on, the focus was on pediatric pneumonia. We are also working on other mechanisms to optimize oxygen, especially the main concern about insecurity of oxygen here is the electricity ensuring electricity or power availability 24 hours a day. So we are looking and having a conversation to introduce oxygen medium pressure reservoirs to be able to address this gap. And we are discussing with partners, and hopefully by May, we shall be able to import or procure some of these reservoirs to address that gap. So what have been our challenges? Those have been the opportunities. We're trying to look around. We want to keep pneumonia high on the agenda, but we have experienced some challenges. Whereas a lot of improvement in availability of commodities for pneumonia has taken place, we've seen a discrepancy. Most of our partners and the procurement has gone to the commodities at the community level. And sometimes we have stockouts at the health facility where patients are being referred. The commodities also at the facility are also used for other purposes beyond pneumonia, which sometimes is not very which is not planned for at the central level. So stockouts still remain a problem at the health facility, and sometimes we have stockouts as high as 40%. The other challenge has been a policy discrepancy on having injectable antibiotics at the lowest health center level 2. We've had a challenge to update this policy because the country is in the process of phasing out these health center 2 levels to health center 3. This has been a gradual process, and we have not been able to cover all parts of the country. So we are hoping as we upgrade, we'll be able to have these antibiotics, but we need to have an interim policy to support availability of these pre-referral medications. The third challenge has been a general systems gap in strengthening the networks of care, resulting in breakdown of continuity of care when patients are referred across different facilities, including moving from sometimes public to private. So our new emphasis now is to see whether we can actually improve the quality of care referral facility, referral standards. We're trying to operationalize the WHO standards to improve quality, efficiency, and responsibility. And we are hoping also to learn from the experience from COVID to be able to leverage some of the resources as we push for the control of this pandemic, which is affecting many patients and which is involving actually interventions which are closely linked to control of pneumonia in children, both in terms of interventions, but also the symptoms and the target group. We are also having a challenge of we've had a challenge of trying to be able to look for more innovative funding for pneumonia. And the main reason has been the overwhelming pandemic interventions and emphasis. COVID-19.
Dr. Jessica, I'm very sorry, but can you please wrap up 1 minute, please?
So this is my final slide on where our final presentation submission on where are we looking ahead? What is the way forward? Our way forward is to utilize the return on investment analysis, which we are doing. We have developed a dashboard for pneumonia and tracking the availability of services. And we are hoping that this is going to be a very strong advocacy tool. We are also developing a new RMN shaping plan, and we are making sure that we include pneumonia, which will be costed and funded by the GFF funding, since this is all under the investment case. We are also working on trying to make sure that we mobilize resources for our oxygen plan, and also improving the infrastructure, upgrading, as I've mentioned earlier on. And also we are working on trying to make sure that we scale up our prevention, promotion, and treatment strategy for pneumonia, which brings on more players and expands our platforms, including the private sector. I would like to stop there, and I want to thank you for listening to me.
Thank you very much, Dr. Jessica. Now I would like to invite Dr. Nusuna from Malawi, please.
Thank you so much, Elena. Discussing around opportunities, challenges, and looking ahead, while the rest of the world continues to face the pandemic challenge, Malawi has not been isolated. Rather, we have had opportunities around that where we experienced some successes during the pandemic. The Ministry of Health, with its leadership, managed to develop a national oxygen roadmap, as well as decentralizing oxygen management where procurement of the oxygen plants in 2 tertiary facilities were instituted and installed, and providing management for patients who are fighting for breath. So the ministry, within the same, as an opportunity, tried to do and facilitate coordination, where with engagement of partners like UNICEF at regional level, we tried to make sure that there is an advancement and the continuity of service provision alongside efforts that we continue to fight for, especially looking at pneumonia management, where we had to continue the engagement processes in the implementation of the integrated community health interventions, where during the period, 1 year on, we've been able to define packages for community-based interventions, looking at specifics in terms of ICCM and pneumonia management, as well as birth asphyxia and preterm birth management at a facility level, as well as community level for ICCM. So during the year, I would say we have had some progress. I would term it as good, but not excellent, in terms of implementation of the integrated management of childhood illnesses, because we have sustained and scaled up implementation of ICCM services, which is over 89%, and the MCI implementation at primary healthcare facility level. And within the process, we are currently working on having a comprehensive ICCM gap analysis, looking at what are the things that we need to comprehensively look at addressing within the pandemic, but also going beyond what we may not expect moving towards 2030. Next. Despite talking about those opportunities that have occurred for Malawi, we have had to experience challenges. These that have affected smooth running of the implementation, looking at the competing priorities that has come with COVID. At the same time, looking at how do we emphasize pneumonia management at all service delivery points that we have. And we know in our settings, environmental issues have played and continue to play a role. But as a ministry, we are building and trying to build resilient health systems that will enable us to handle the pandemic through engagement of multi-sectoral task forces and collaboration initiatives, intersectoral, but also inter-ministerial, because we have to work with other sectors of government and indeed partners, and indeed effective implementation of the same. And the other things that we have observed over the years, rather an availability and the insufficient acute respiratory infection timers. Timers are a diagnostic aid that would help us move forward. So what we would intend to do and what we have engaged in the ICCM gap analysis is to mobilize resources, but also strengthen the provision through the engagement, the ICCM investment case in trying to finance and look for resources to provide for these timers, as well as the availability of dispersible amoxicillin, which has been a challenge in the management of sick infants, but also children at both community level, but also at primary health care level. So these are some of the critical challenges that have remained with us. But looking ahead, we would want we would want to aim at trying to bridge and build provisionally accommodating in terms of providing oxygen availability beyond beyond just the COVID, because we have to facilitate and ensure pneumonia management, access where there is fighting for breath, and indeed chest indrawing pneumonia requiring oxygen support, ensure uninterrupted supply of the same. Next. Finally, what we intend to do in the current setup, looking at one, sustaining the provision of ensuring sustainable management of the COVID management approach, which the Ministry of Health has already kickstarted and is championing. We want to ensure that at each level, or rather at each regional level, we have also another tertiary facility installed and having an oxygen plant with the adequate production needs, as well as identifying selected strategic districts to install these. The availability of oxygen will facilitate availability of oxygen for pneumonia management as well for our health facilities, including the oxygen concentrators, which require availability at the levels of the primary health care level. We know procuring oxygen concentrators alone is not adequate, but rather we need some backup because electricity, this end of the world, is still a challenge. So power, and in terms of solar, is a priority. Looking at how do we maintain and sustain utilization of concentrators for our cases. And the other thing that we are looking ahead on in terms of oxygen is to do scaling up and decentralization of the use of the CPAP machines in the terms of providing quality case management for newborn care, especially at the primary health care level, but also at the referral level. Comprehensively, within the financial needs, while we are looking at oxygen production, sustainability, and maintenance, for child health strategy, we are looking at a child health redesign, where we want to redesign IMCI interventions so that we have an intensified and aggressive approach in terms of providing services for newborn and child health, while facilitating commodity availability, strengthening mechanism, but also taking advantage of the global financing facility that my colleague from Uganda was highlighting. But we are there, but we have not yet gotten how much we will get support on. Looking ahead as well, we want to have a finalized, but at the same time, comprehensive ICCM gap analysis that we are currently working on. And beginning this week, we will be finalizing concepts as well as validation of the data using the community health population tool to have this final and presented towards the ICHC conference that may be happening in April this year. But at the same time, we will be having the ICCM roadmap, planning, as well as invested towards moving 2030 for our goal in terms of trying to contribute towards the reduction for childhood and the newborn mortality, assuring health for all in Malawi as a global village. Thank you, moderator.
Thank you very much, Dr. Sona. Now we finish our 3 speakers. We're missing one from Indonesia, but when she comes online, then we'll kind of try to cover in the next session. In the meantime, I would like to kickstart our short dialogue. And then this dialogue will be also participated by delegates also committed to participate in this session. So please, delegates who would like to make comments or raise any questions, please raise your hand, then I will invite you to speak up. And in the meantime, I would like to kickstart this short dialogue by asking the speakers, we have 3 speakers, to name one thing, just like one aspect that, in your opinion, would really help ensure more financing to child health, especially childhood pneumonia. Is it more scientific evidence to convince the policymakers, or is it cost-benefit analysis to show the economics of that? Or is it more advocacy to raise the general public's understanding of the issue? Dr. Sona, you want to start first?
Yes, one particular issue is associated with the fighting for breath is one key component that we are advancing as the Ministry of Health, is to do with the, assisting and supporting breath asphyxia and newborns. So an establishment of CPAP machines for us has proven to work wonders, especially for children in few sites, especially referral facilities, that had championed the implementation and use of the CPAP machines, because there has been tremendous progress in terms of recovery and indeed reduction in mortality of newborns, which has been a contributor towards the whole progress of our under 5 mortality in Malawi. So that is one of the key priority components for Malawi in dealing with the neonatal health. So this beyond CPAP machine availability, but also support as well as capacity building, we are looking at making them available. How do we make them available? We have institutions in Malawi, so we are engaging through the Ministry of Health, trying to lobby for resources to have them locally manufactured or produced, so that one of our institutions, engaged in engineering for this, can produce and indeed distribute locally, but also send outside the country. Because as a model, we have one that we shared and it demonstrated during the World Pneumonia Day commemoration, which happened in November this year. So that is one of the key institutional arrangement that the Ministry of Health is trying to do beyond engaging newborn care for ICCM, but also for primary level implementation. Over.
Thank you very much, sir. Dr. Dan, you mentioned about the very important issue of vaccine and also like the challenges. And in order to mobilize more resources for the more vaccine availability, what actions should we take?
Thank you for your question. Just I mentioned before, the consideration of introducing one vaccine into EPI is complex. So there are many factors will influence the inclusion policy, including the disease-related factors, the vaccines, the supply factors, and also the policy-making related factors. And also, although targeting one factor, the population or the policymaker have different values for the same factor. So I think the cost effectiveness is just one of the important factors to consider in resources allocation decisions. So I think for the developing countries, we have to make scientific data or a method to make the evidence-based recommendation to comprehensive assessment of the relevant disease burden and vaccine safety effectiveness, and also the health economic evaluation, production and supply capacity, and other factors. So need to qualify and evaluate the weight of these factors and to prioritize which vaccine is better for the inclusion. And also, in addition to the inclusion of the new vaccines into EPI, there is also, I think, in developing countries, there are the replacement of the old vaccine. So it is, so I think the qualified assessment for all these factors will help us to make the evidence-based decision to prioritize all these vaccines. Thank you.
Thank you very much, Dr. Dan. We have among the delegates, Dr. Yame Ugo from Burkina Faso raised hand. Please, sir.
Merci bien. Je voudrais simplement dire grand merci aux panélistes qui ont partagé leur expérience. Et j'ai compris que avec ces expériences qui sont centrées sur la prise en charge des cas sévères avec l'utilisation des oxymètres, et moi, mon intervention portait surtout sur un commentaire sur la prise en compte et surtout des cas qui sont simples au niveau communautaire. Et je sais que pour les cas de pneumonie, la plupart du temps, le vaccin est très efficace, certes, mais aussi il faudrait que nous arrivions à mettre en place un dispositif pour un suivi régulier des enfants à domicile avec l'accompagnement de leurs parents. C'est en ce sens que nous allons pouvoir réellement éviter que beaucoup d'enfants ne basculent dans les cas sévères et de façon indirecte, nous allons économiser en matière de financement. Soigner un enfant quand il manifeste des signes simples de pneumonie au niveau de son domicile par un suivi rigoureux avec les agents de santé à base communautaire, ça nous permet d'éviter d'arriver au niveau des hôpitaux où le coût sera encore 10 fois ou 15 fois plus cher. Ma question aux panélistes est la suivante. De par ce qui a été réalisé comme expérience, quelle est votre expérience en matière surtout de mise en œuvre d'intervention dans les ménages pour éviter d'avoir des cas compliqués de pneumonie? Au Burkina Faso, nous sommes dans la dynamique de pouvoir mettre en place des ménages modèles qui répondent à des critères pour faire en sorte qu'il y ait pas de cas graves, que ce soit de pneumonie, que ce soit de paludisme, ainsi de suite. Merci à vous et bonne suite.
Thank you, Dr. Yameugo. I see Dr. Jessica also raised a hand because Dr. Jessica also mentioned about integrated community case management, which may be also partly responding to Dr. Yameugo's question regarding the model for household level interventions. Please, Dr. Jessica.
Thank you very much for that question. We have a strategy called Prevention, Promotion, and Treatment of Pneumonia. We've developed a strategy and an action plan. And the main emphasis of that strategy is to make sure that we are combining all those, we are converging all those interventions. And at the community level, whereas we have case management, we also have a program which is fostering key family care practices.
Dr. Jessica, I'm very sorry, your voice is really soft.
Okay, sorry, let me improve. So we have a program at the community level, which is fostering prevention, promotion, and treatment of pneumonia interventions. And this includes key family care practices, including breastfeeding and infant feeding, immunization, care seeking for immunization, and also trying to make sure that when you get treatment for pneumonia or from the community health worker, the family makes sure that the mother gives the medicine completely. So our emphasis for that model is on pushing for household and community practices to ensure that we're able to prevent but also treat adequately when pneumonia occurs. This is in combination with the case management, drug supply, which is done by the community health worker. So that is the model we are using. They also encourage mothers to go for immunization, and this starts all the way from antenatal. They counsel them from antenatal. So we have 23 key family care practices. Some of them are relevant to pneumonia.
Thank you very much, Dr. Jessica, for elaborating the integrated case management model. And then it's more intervention at the community level. And then not only just like a pneumonia case, but like overall from the newborn care and the child health interventions, like a more integrated way. Because your voice was very small, so I kind of tried to summarize for the participants who may haven't clearly heard you. I do not see much comments from the delegates. From the delegates, any further questions or comments to be made? Actually, because this session is on financing, so I kind of feel obliged to ask this question I'm working for Asian Development Bank and one of the international financial institutes, and then we're also lamping up our financial resources for the member countries' intervention in health. So my next question to the speakers as well as the delegates is how international partners can best support health ministries or Ministry of Finance in that matter to increase domestic spending on child health as countries emerging from the pandemic. We're not yet fully out of it, but like how can we support you better in addressing child health? Thank you. Dr. Jessica, you wanted to respond first?
Let me try. I think
Ma'am, can you speak up, please? Thank you.
I think much as COVID has been a competitor, we in Uganda, for example, we have also seen it as an opportunity because one of the pillars we are running as a coordination.
Est-ce que je peux prendre la parole pour répondre à cette question?
Dr. Doucouré, can we just...
Je voulais juste répondre à la question qui a été posée par Madame la représentante de la Banque asiatique de développement.
Yes, please, sir.
C'est possible? En fait, moi, je voulais dire par rapport à l'importance que les banques vont aider les pays à développer la santé. Moi, je pense qu'aujourd'hui, les partenaires peuvent aider les pays par l'augmentation des dépenses nationales pour la mobilisation des ressources. Chez les enfants, je pense qu'aujourd'hui, il y a beaucoup d'acquis qui ont été observés dans la santé des enfants. Je pense qu'aujourd'hui, l'une des forces, c'est de maintenir ces acquis d'abord, mais aussi aller vers d'autres, à travers le plaidoyer. Le plaidoyer est extrêmement important. Quand on sait qu'aujourd'hui, le plaidoyer pourra contribuer à mobiliser davantage pour la santé des enfants, je pense que c'est extrêmement important. L'autre aspect, c'est par rapport à, ça peut être des dons, mais aussi des subventions, mais sous forme de prêts. Aujourd'hui, par exemple, je prends l'exemple de notre pays, il y a des prêts qui sont faits, mais qui ont un délai de remboursement qui est très long, mais aussi un intérêt qui est très faible. Nous avons essayé aujourd'hui au Sénégal, il y a des infrastructures qui ont été construites sous forme de dons, mais sous forme aussi de prêts, et de prêts avec vraiment un prêt concessionnel. Et le gouvernement du Sénégal pourra même payer après avoir 10 ans de prêt, d'avoir contacté ce prêt. D'autres aspects, je pense qu'aujourd'hui, il y a des acquis en termes de vaccination. Il faut continuer à développer cette prévention chez les enfants, la promotion, la vitamine A, la vaccination. Je pense là, c'est extrêmement important. Donc, à mon avis, c'est des efforts qu'il faudra maintenir, mais aussi essayer de voir avec la pandémie. Aujourd'hui, les budgets des États, on est obligé de faire une réorientation budgétaire pour prendre en compte l'aspect Covid, mais la santé infantile ne doit pas être laissée en rade. Merci.
Thank you very much, Dr. Dukure. May I invite Dr. Jessica again? Dr. Jessica, I think you need to speak up. We cannot really hear you, your valuable comment. Thank you.
I was just saying that much as COVID has been a disruption and a competition in terms of resources, it can actually be an opportunity. One, for example, because of the focus on pneumonia, I think we can situate the child within the interventions for COVID, for pneumonia, so that we make sure that we are at the center of the conversation. I think we need to work like our country, our continuity of essential services pillar in COVID has become very active, so that we are also working and negotiating around the same resources. I think it's going to be very difficult to come out of this expense for COVID for some years. We are also looking at the vaccination. I think some people have gone in a very vertical manner, but also some countries are trying to make sure that as they roll out the new vaccine, they're also strengthening the other vaccine. So I think it's actually an opportunity for us to establish, first of all, the infrastructure, but also to be able to provide some capacity building for our health workers to be able to handle our services. In Uganda, when COVID came, the government was given permission to reallocate funding for maternal child health for COVID, especially from the World Bank loan. So a lot of money was taken by the World Bank loan, promised to bring back the money, because that means that even in the future, probably won't be able to have additional resources. But we need to situate and center childhood, probably align it better with the COVID. We need to be part of the COVID conversation. We need to be part of the participants coordinating and discussing COVID. We should not sit on the side. That's the only way we can actually get more resources. But also we need to analyze our gaps and needs. We need to work out our investment cases. We need also to present some results on the impact, on the returns we are making in the investment case. So despite the challenges of measurement, we need to make sure that measurement is very actively prioritized. Thank you.
Thank you very much, Dr. Jessica. I will now invite Professor Saidullah from Bangladesh as our last commentator of this discussion. Thank you. Professor Saidullah, please.
Yeah, thank you very much. What I'm going to do actually, use my time to say something about the Bangladesh context that we have done during the pandemic in terms of fighting for breed, that is for pneumonia. Let me give you a little bit of the background. In Bangladesh, we made significant progress in reduction of child mortality rate in recent decades, but yet 24,000 children under the age of 5, they die from pneumonia per year. We have got integrated management of child illness in place in the district level, sub-district level. Below to that is union and community clinics. Good to know about that PCV vaccine is included in the routine EPI, and we have got a very sustained good coverage of immunization. Now, having said that, I'll be talking very briefly about the financing during the COVID pandemic time. We all know that COVID-19 pandemic has put us in challenges and also made some opportunities. Now, regarding the financing, I would say that we have got two important programs. One is National Newborn Health Program, and one is IMCI. There are two lead programs in the ministry. And $2.8 million the government of Bangladesh has allocated for the year 2021 for procurement of logistic like pulse oximeter, then ARI timer, medicines like dispersible amoxicillin tablet, gentamicin, and a small amount of that is also spent for training and social and behavioral change. Then we have also the co-financing from the government side is about $75 million for procurement of PCV vaccine, and rest actually we get from the Gavi. And also the UNICEF has done a tremendous job during the pandemic. They have supported the public hospitals to establish the, continuous oxygen supply system, particularly liquid oxygen plant, and that amounts to about $12.28 million. What is actually the benefit of this? That it's going to give the leverage to use this right now and even in the post-pandemic era. So I will talk a little bit about the innovation, just in brief, maybe 1 minute. That one of our international research centers, ICDRV, they have done a feasibility research study introducing pulse oximeter in the routine IMCI service in Bangladesh, this one. Then also they have done a district model of implementation of pulse oximetry, where it is feasible and how does it work. And also a feasibility and acceptability phase of implementation study on innovative bubble CPAP that you know that some African countries are now using it. The last one that I like to say, Projonmo Research Foundation, one of its outlet of the Johns Hopkins University, that they have done a research on community use of digital auscultation to improve diagnosis of childhood pneumonia in a remote area in Bangladesh. This innovation will finally or eventually generate evidence on improved screening and case management of childhood pneumonia. So during this 1 year, Bangladesh has done this in terms of financing, what I said before, and also in terms of innovation. Thank you. Over.
Thank you very much, Professor Saidullah. That's a really good segue to our next topic. Our second topic is innovations. We have two speakers today. Dr. Amadou Dekure is Director of Maternal and Child Health from the Ministry of Health and Social Action, Senegal. And we also have Professor Lisine Tisenge. She is Director of Medical Services from University of Teaching Hospital of Kigali, Rwanda. Dr. Dekure, please. Dr. Dekure, kindly.
Excusez-moi, je n'avais pas ouvert le micro.
Thank you, sir.
Ok, je disais que je voudrais à l'entame de mes propos vous présenter les salutations de Monsieur le ministre de la Santé et de l'Action sociale du Sénégal, Monsieur Abdoulaye Diouf Sarr. Et au nom de la délégation sénégalaise composée de différentes directions et services du ministère de la Santé et de l'Action sociale, d'universitaires et des partenaires techniques et financiers, nous avons le plaisir de partager avec vous l'état de la mise en œuvre de projets innovants que sont les sprints et les Team C. Diapo, s'il vous plaît. Donc, pour dire que juste que ces projets sont alignés dans le cadre stratégique et ici dans le cadre de la réactualisation des protocoles normes en santé reproductive maternelle, néonatale, infantile et de l'adolescent, avec plusieurs composantes qui sont la mise à disposition de l'amoxicilline dispersible avec la formation nationale d'approvisionnement. Il y a aussi la mise en place d'oxymètres de poule et d'oxygénothérapie qui aujourd'hui sont au niveau même primaire du système de santé. Vous savez qu'il y a 10 ans de cela, l'oxygène se trouvait au niveau des hôpitaux, c'est-à-dire des hôpitaux régionaux. Mais aujourd'hui, on trouve cet oxygène au niveau des centres de santé et même au niveau des postes de santé avec ce projet innovant. Et l'autre composante, c'est la recherche et la digitalisation. Et comme vous le savez, le Sénégal aussi, depuis le 2 mars, est en train de vivre la pandémie à COVID-19, qui au début, il faut le dire, a entraîné une rupture dans la continuité des soins, mais au fur et à mesure, cette pandémie a constitué une opportunité puisqu'elle a contribué à rehausser la disponibilité de l'oxygène au niveau primaire, c'est-à-dire au niveau opérationnel, surtout au niveau des centres de santé. Nous allons revenir. Et par rapport aux opportunités, il faut dire que ces projets sont mis dans un cadre multisectoriel, multipartenariat intrasectoriel avec les directions du ministère de la Santé, parce qu'il y a plusieurs directions qui sont concernées. Il y a la DSME, il y a la direction du système d'information sanitaire, il y a aussi d'autres directions comme le Service national d'éducation pour la santé. Il y a aussi un partenariat avec l'université, avec les sociétés savantes, mais aussi avec les collectivités territoriales quand on sait que la compétence, la santé au Sénégal est une compétence transférée. Et tout ceci selon une approche communautaire. Vous savez, on a un réseau communautaire qui est très dynamique au Sénégal et qui est structuré en ce qu'on appelle les acteurs communautaires pour la promotion de la santé, mais et les acteurs communautaires pour les soins. Et ces acteurs jouent un rôle extrêmement important dans la demande en soins, mais aussi dans le dépistage précoce de certaines pathologies pour éviter leurs complications. L'autre aspect, c'est la sécurisation des produits. Aujourd'hui, avec l'UNICEF, on a à acquérir de l'amoxicilline disponible, mais vous savez, on a une pharmacie nationale d'approvisionnement et cette pharmacie, l'avantage que nous avons est même représenté au niveau des 14 régions du Sénégal, ce qui permet un peu de rapprocher davantage les produits à la population. Et même, il y avait une expérience qui a été mise en pilote qu'on appelle le Yexina, c'est-à-dire plus proche de moi, mais aussi chez moi, ce qu'on appelle le Yexina, qui permet de rendre disponibles les produits même au niveau du point de prestation. Et l'autre opportunité, c'est la contractualisation avec un privé qui a permis un peu d'accentuer la mise en place des équipements, mais tout ceci a été fait en concert avec le ministère de la Santé, qui a une direction chargée des infrastructures de l'équipement et de la maintenance. Tout ça, c'est important dans le cadre d'une perspective de pérennisation. Vous savez aussi, la pneumonie au Sénégal est considérée comme une haute priorité par les autorités, et là, c'est pris en compte dans tous nos politiques. L'autre opportunité, c'est la gratuité des soins chez les enfants de moins de 5 ans. Au Sénégal, depuis 2013, on est en train de mettre en œuvre ce qu'on appelle la couverture maladie universelle avec plusieurs composantes, dont la gratuité des soins chez les moins de 5 ans. Aujourd'hui, au Sénégal, tous les enfants âgés de moins de 5 ans sont pris en charge gratuitement au niveau du système sanitaire. Maintenant, pour une pérennisation, nous sommes en train de tester l'enrôlement des enfants de moins de 5 ans dans des mutuelles de santé communautaire. Et là, ça a commencé. L'autre aspect opportunité, c'est le plan d'investissement santé. Aujourd'hui, tous les pays doivent apprendre de la COVID-19 et renforcer le système de santé. Et à cela, le Sénégal a élaboré un plan d'investissement santé dont le budget est estimé à $1 milliard qui comporte un peu le renforcement du système de santé en termes de redynamisation des infrastructures, en termes de dotation d'équipements adaptés, mais surtout en termes de renforcement du personnel qualifié. L'autre aspect, c'est la mise en œuvre du projet ISMEA dans 6 régions sur les 8 régions et qui permettra de mettre à l'échelle ce que nous sommes en train de faire dans le cadre du projet TIMC Sprint. Et il y a aussi le Fonds mondial, dans le cadre de nous sommes en train de développer ce qu'on appelle la prise en charge des cas de paludisme à domicile. Et là, dans le contexte de redynamisation des soins de santé primaire, nous sommes en train d'intégrer d'autres soins, comme le départage systématique, comme aussi la recherche des enfants dans le cadre de la vaccination, et ça pourra un peu contribuer à améliorer les indicateurs en termes de vaccination contre la pneumonie. Il y a aussi la recherche de tout, il y a la recherche de diarrhée. Tout ça fait que c'est un paquet intégré qui est proposé aujourd'hui au niveau communautaire et qui permet une prise en charge précoce, mais surtout la prévention des complications. Diapo, s'il vous plaît. Diapo. Le défi, c'est la qualité des soins pédiatriques. Vous savez que la santé néonatale ne peut pas connaître des progrès si on n'investit pas dans la qualité. C'est bien de donner des soins, mais aujourd'hui, quand même, le focus doit être mis sur les prestations de qualité. Et quand on dit prestations, il y a d'abord l'infrastructure, il y a l'équipement et le personnel. Le personnel doit être qualifié. La maintenance préventive et curative. Aujourd'hui, avec ce projet, on a innové de telle sorte qu'aujourd'hui, l'infirmier chef de poste qui est qui est au niveau le plus bas sanitaire, de l'appareil qui lui a été octroyé. Il y a aussi le renouvellement des équipements, ça c'est important. Chaque équipement a une durée de vie et à un moment donné, il faut cet équipement. La continuité des soins et résilience du système en période Covid. Là, nous sommes en train de vivre la Covid-19, mais seulement c'est Covid. Il y a aussi d'autres pathologies qu'il faudra prendre en compte. Et le système doit être résilient par rapport à la Covid-19 qui tend à être endémique. Et je pense que même les soins doivent être offerts à tous ceux qui présentent d'autres pathologies. La gestion multisectorielle des déterminants des affections respiratoires. Vous savez que la santé, il y a ces déterminants. Aujourd'hui, nous travaillons avec le ministère de l'Environnement, surtout avec le centre de la qualité de l'air, qui nous donne chaque jour l'indice de la qualité de l'air. Nous travaillons aussi avec d'autres secteurs comme l'université, qui sont les sociétés savantes, et qui nous permettent quand même de prendre nos décisions sur des bases factuelles. Le passage à l'échelle et la pérennisation, nous sommes en train de mettre à niveau, nous sommes en train de dérouler ce projet au niveau de certains districts sanitaires et nous voulons à l'issue de ce test de passer vraiment à l'échelle et descendre ça à tous les pays. La mobilisation de financement domestique et accessibilité financière, surtout la mobilisation de financement domestique qui est le seul gage pour la pérennisation de cette initiative. Et là, comme je l'ai dit tout de suite, il y a aujourd'hui des initiatives qui sont mises en œuvre à travers le partenariat public-privé, ce qu'on appelle il y a aussi ce qu'on appelle à travers les partenaires techniques et financiers. Et là, nous sommes en train de développer des stratégies comme les prêts concessionnels. Nous pensons qu'avec ces prêts, pourront contribuer à mettre en place des infrastructures dignes de ce nom pour améliorer la qualité des soins. Le renforcement continu des compétences du personnel. Vous savez que dans nos pays, en général, il y a ce qu'on appelle un turnover très important qui fait que les agents de santé, s'ils sont affectés dans des zones périphériques, au bout de 2 ans, 3 ans, ils voudraient vraiment se rapprocher un peu de la capitale. Là, c'est valable dans les pays en développement. Et là, je pense que l'un des défis, c'est de faire de telle sorte que le renforcement de capacité de ce personnel soit vraiment continu, ou même faire de telle sorte que la formation de ce personnel se fasse au niveau des écoles de base. Mais s'il y a la rétention, je pense que là, c'est un défi qui est là, surtout en termes de motivation. Et le Sénégal est en train de voir des mécanismes pour pouvoir un peu faire la rétention. Et là, dans le cadre de la mise en œuvre du projet ISMEA, il y a un important volet rétention qui fait que les personnes vont rester sur place pendant au moins 3 à 4 ans au niveau de leur travail dans les zones périphériques. Par rapport aux perspectives, c'est le plan d'aménagement de la qualité des soins. Il y a aussi l'acquisition d'oxymètres multimodal qui permet de mesurer la fréquence respiratoire, le niveau de saturation de l'oxygène, la fréquence cardiaque et le taux d'hémoglobine. Tout ça entre dans le cadre de l'intégration vraiment des soins. Il y aura aussi des recherches qui seront menées pour évaluer un peu l'impact de l'intervention, mais aussi évaluer le coût et l'efficacité de cette intervention. Il y a la documentation qui va nous permettre quand même de documenter tout le processus, mais aussi si on veut passer à l'échelle, ça va nous permettre d'avoir les grandes orientations et aussi les bonnes pratiques et les stratégies à mettre en œuvre pour aller à l'échelle. Le plan d'équipement, je l'ai dit, avec le PIS, ce qu'on appelle le plan intégré santé sectoriel 2020-2024, qui permettra une amélioration notable du plateau technique, mais aussi le passage à l'échelle de l'amoxine et de l'oxygénation. Et là, comme nous avons une formation nationale d'approvisionnement qui permet l'approvisionnement en médicaments et la distribution au niveau de points de prestation, ça sera pris en compte et établi dans la liste des médicaments essentiels. Et là, pour terminer, vraiment un financement innovant à travers des taxes, mais aussi à travers ce qu'on appelle la responsabilité sociétale d'entreprise, mais surtout vraiment avec des collectivités territoriales. Quant au fait que la santé est une compétence transférée, aujourd'hui, avec la santé communautaire, nous pensons que vraiment on peut développer cette stratégie. Over. Merci.
Thank you very much, Dr. Dukure. Now, may I invite Professor Chisinge from Rwanda, please?
Hello, my name is Lizine Chisenge. I'm the Director of Medical Services in Watkins of big public hospitals in Uganda. Next, please. So I was asked to talk about opportunities and challenges, but also to see the way forward 1 year after the forum we had in Barcelona. So during the COVID-19 pandemic, we saw that this pandemic has brought really new challenges, but also opportunities in reducing child pneumonia deaths and strengthening the health system in our country. So we think that this pandemic, after this pandemic, we expected to reduce other airborne disease through COVID-19 preventive interventions put in place, like wearing masks, hand washing stations, which are in all public places, but also that opportunity where parents stay at home and now many are working from home and they have more time to care for their children during this COVID-19 lockdown. Another opportunity Rwanda has invested by optimizing and expanding the oxygen plant of one of tertiary hospital in Kigali. And this plant now is able to serve oxygen to lower hospitals. Additionally, some equipment have been procured or donated through different grants. And this really is a big opportunity to manage child pneumonia too. Also, Minister of Health, in partnership with the Clinton Health Access Initiative, CHAI, completed an assessment for respiratory care capacity in Rwanda and now has a good plan to mobilize funds for increasing oxygen production capacity in the country. But also enhanced training of health providers on infection prevention and control during this pandemic was done, and this will ensure that during this pandemic, we had really this opportunity to ensure continuity of essential services at the community and health facilities. Also, pediatricians intensified the trainings of healthcare providers in district hospitals through their mentorship activities due to lack of clarity on COVID-19 in children early on. During this last year or so, we increased the risk communication messages, but also routine discussion on data and corrective recommendations by multiple stakeholders, organization of e-learning and remote trainings via Zoom or Webex. It helped really to improve knowledge and the practices on childhood care, including pneumonia. Next, please. So as challenges, we continue to see a persistent need for effective diagnostic technologies. So blood culture, imaging, other lab works. So to diagnose and treat severe childhood pneumonia cases. But also the knowledge gap in the sensitivity patterns of antibiotics used in the treatment of pneumonia in children still our challenge. The inability to correctly diagnose pneumonia impacts also accuracy of pneumonia case reported. Another challenge is insufficient oxygen in our working areas in hospitals can impact the management of pneumonia. So this is one of our challenge, but also during this pandemic, we saw that there is a possibility to handle this issue. So we continue to advocate for having enough oxygen. So insufficient capacity, for example, skilled staff, or also enough number of staff, infrastructure, commodities, and equipment in pediatric intensive care units. For example, monitor CPAP ventilators, and shortage of staff to monitor critical cases is one also of our challenges today. Thank you. The next, please. Next, please. So looking ahead, we think that enhancing use of algorithms in the management of childhood disease can help us to diagnose well from down, we can diagnose, including pneumonia and other childhood disease. And this, we think, will be informed by one of ongoing research projects, which is done between Ministry of Health, some partners, but also the Pediatric Association. Another point, we are looking ahead to improve diagnostic capacity and implement the new updated data collection tools in the health management information system for real-time and accurate reporting of pneumonia and timely remedial actions. We are looking ahead to scale up also some integrated digital health solutions to improve quality and the continuity of care. Also, we will ensure sufficient oxygen in health facilities and the ambulances during the referral. Another point, we will coordinate with partners to ensure continued support to maternal, newborn, and child health activities, including implementation of quality of care standards and data use for decision making. So we are looking ahead also to reinforce IPC, to continue to reinforce IPC as we learn from this rare pandemic, especially for reused accessories, but also increase and equip PQ units in all referral hospitals to avoid delays in urgent critical care. We will continue to strengthen capacity of health facilities like human resources, supply chain infrastructure to improve the management of critical care. So we will also enhance capacity to continuously monitor sensitivity of antibiotics, especially those commonly used to treat pneumonia. For example, you know that amoxicillin is commonly used in the community, and really this is something we need to tackle on. So we will also strengthen linkages and integration of programs in health activity designs, especially for nutrition, for effective management of pneumonia at primary healthcare facilities. Thank you.
Thank you very much, Dr. Tisenge. So we actually have short discussion. We are actually running out of time, but if you allow, we will have around 10 minutes of discussion. It's a very important issue of innovation, not only just technological breakthrough, but also doing things differently, as also mentioned by a few speakers and during the financing session. So I would like to open the discussion to the speakers as well as the delegates, please. Any comments or questions to the speakers? For general participants, would you please pose your questions on the chat box? Thank you. I have questions to the speakers. Dr. Dan Wu, on our first speaker during the financing session, talk about vaccine, and then she also mentioned about there are not enough of like suppliers or developers of vaccine, and then most probably that's because these private sector pharmaceutical companies see that there is not enough of demand for the vaccine for child pneumonia. So whether there is something we can learn from this global facility aggregating the demand, for example, like a COVAX actually accelerated the vaccine development as well as by aggregating demand among the developing countries, also supporting developing countries to have better access to vaccine. So whether there is some implication we can learn from this. Dr. Tsenge, do you see any possibilities that we can also adopt the same model for the pneumonia vaccination?
I think, as I said, really COVID-19 pandemic was a model to learn from many challenges and maybe seeking for solutions. So COVAX really was an innovation to accelerate vaccine in the world. And I think if we identify all countries where we don't have vaccine for pneumonia, we can maybe mobilize with different partners to see in which forum or in which framework they can really channeling those vaccines for a better quick intervention to vaccinate children. I think this is an innovative way. So we can use the same way to mobilize and see how many children in need of vaccine and which organization can help to produce this vaccine and quickly and to disseminate the vaccine everywhere it's needed. So I think it's a good opportunity.
Thank you very much. Any other comments on the innovation side? Kind of we doing things differently. I mean, not necessarily of like a high tech and advanced technology use, but adapting and adopting what's been already available, but like try to address the child health issues. I guess the time is already late, and it's the session has been very informative and full of insights to digest for the panelists as well as country delegates. Yes, Professor Saidullah from Bangladesh, please.
It's just a last moment comment. You know, this pandemic, particularly, as I said, that put us on challenges and also brought some opportunity. Now, we had in our country the health facility preparedness and readiness assessment for COVID-19 response conducted in the month of June and July last year, that is 2020. And that particular exercise also helped us to find out the scenario of the childhood problem, including the pneumonia. And that particularly the preparedness and readiness also is indirectly or I would say directly going to address the pneumonia cases who are actually very sick and get admission in the hospital are being addressed. That's the point that I wanted to make.
Thank you very much, sir. It's certainly the challenging time is testing our dedication and creativity, certainly. As I mentioned, financing and innovation are all about prioritization. However, given the finite resource, policymakers always face challenges when it comes to prioritization. Other action areas of the Global Forum Declaration, such as pneumonia control strategy, targeting vulnerable population, tracking of the progress in an accountable and transparent manner, and the stronger partnership, leveraging the resources of the partners. These are all key to successful prioritization. because it strengthened our advocacy, evidences, and really like kind of combining our commitment, hence mobilizing more financial and intellectual resources towards this important cause. I would like to conclude this very important and informative roundtable. Thank you very much for your valuable contributions today. And we hope the 2 remaining roundtables discussions will reaffirm every stakeholder's commitment towards the global target to reduce the child pneumonia deaths and help us refine the course of actions while countries still deal with COVID-19. As many participants highlighted, it's a challenge, but it's also opportunity for us. All the best and stay safe. Thank you very much.
Thank you so much.
So it was nice. Thank you so much for this arrangement. It was great.
Thank you,
Bye-bye.
Dr. Sonam.
Thank you. Thank you, everybody.
Thank you, everyone. Thank you.
Stay safe too.